on using a new imaging algorithm which allows us to automatically detect pathologies in the retina. We also aim to investigate the performance in a clinical setting of this algorithm to monitor the disease and detect progression. Age-related macular degeneration is the major cause for blindness in the Western world for patients above 55 age and older. It has a global incidence of 10%. Today, we talk about 196 million people who have the disease, and with an aging population, we expect the number to grow up to 288 million people in 2040. So let me explain a little bit what our work looks like in our daily practice, how we manage the neovascular form of the age-related macular degeneration. These patients need to come in almost monthly for ophthalmology exams. They undergo an imaging of the retina, which is called optical coherence tomography, OCT. And then we as physicians need to get a decision if to treat the patients with injections inside his eye on an almost monthly basis. And we get to this decision based on several parameters: if the patient sees worse, if there's a new hemorrhage in the retina, or mainly our decision is triggered by the presence of fluid which we can see on the OCT. So what does this look like? We actually, as retina specialists, have become sort of a reading center, as at each visit of these patients, we need to review and interpret dozens of pictures at each visit for each eye, and also compare those to the previous images done the months before, and to get a decision if the patient needs to be treated. This puts a lot of workload on us, and as you can imagine, the human eye has limitations. And imagine this setting in a very crowded ophthalmology clinic with dozens of patients each day. So luckily we are in an era where we have new technologies that assist us in our work. While 20 years ago we only looked at the patients with the slit lamp, which you can see on the left. We still use it for every exam, but today we have modern high-resolution imaging tools like the OCT. And today we want to use automated algorithms which can assist us to detect the pathologies in a better way, to quantify the changes in the retina, and allow us a better comparison between visits. So today when a patient comes in, he undergoes these OCT images, and then we need to view the images on a closed system, have a look one by one and compare between the images. And there's no integration of the clinical data of the patients inside this system. Furthermore, we don't get segmented analysis of the images. We only get a general number, what the retina looks like, what the measurements are, and there's no information about the fluid. And as I explained to you previously, this is the main trigger in order to decide if the patients need to be treated. On the other hand, all the clinical information of the patients in the hospital are saved in different systems. This can be demographic information, how much the patient can see, which treatment he receives, in which intervals, and so on and so on. And luckily, today we have a platform which is called MD Clone, which is used in lots of hospitals and health six funds in Israel, which assists us in the hospital to aggregate the disparate data from the different systems into one unified platform, and hereby conduct research. So using this system at Tel Aviv Medical Center, we were able to extract information from more than 2,700 patients with the disease. Another obstacle in our project was that we cannot integrate the imaging and the clinical data into one data set, and this is mandatory in order to analyze the data. Until lately, we needed to save one by one each image, and we needed a person to do so. And of course, this is not an option for such a big project, and this is why, thanks to the BIRAX project, we were now able to upgrade our system and able to build a classified data set which integrates the imaging and clinical data in one. So I will now talk you quickly through the project steps. We are working in a parallel way at Tel Aviv Medical Center and at Queen's University in Belfast, as we will show you later on. So where you see the green green squares, those are the projects that we already managed to finish, which includes the identification of the eligible patients, extraction of all clinical data for thousands of patients and visits, and mainly the extraction of these OCT pictures, and we're talking about 100,000 pictures altogether. In Tel Aviv, we did this by upgrading our system, as I just showed to you, and in Belfast, they were able to extract the images with the help of a company which is called Medisoft. This project would not have been possible without the immense help that we get from the IT, from the computer department in Ichilov, which is really part of our project and supporting us in each step. And after having combined the clinical and the imaging data, we are now looking forward to run the automated algorithm on our pictures, which adds quantified fluid data, layer segmentation, and comparison between the visits, and we're talking about nanoliters of analysis. After having the information from the NOAA algorithm, we will then integrate all this data into one in order to review our treatment protocols and build predictive models which will allow us to treat our patients in a more sophisticated way. So let me show you what we did parallelly in Belfast and in Tel Aviv until now. And one of the major advantages and importance of this project is the huge data set of patients that we were able to recruit from the two centers. And when each of us would be working alone, this would not have been possible. So as you can see, we're talking about more than 150,000 visits of AMD patients from both centers together. And after extracting the clinical data, we are now working on the OCT analysis in order to reach a step where we combine the data and run the prediction models. So let me show you how this looks like. We were able to identify in Tel Aviv more than 4,000 patients. After filtering those that were really treated, we could further divide those into 2,700 patients with almost 3,000 eyes that received treatment. When we look at the patient's characteristic, the main age of patients is about 78 when patients were diagnosed with disease and started the treatment. And as we know from previous reports, there's a female predominance in the disease. You can say that the patients were treated and followed up over years. They received a mean number of injections of 20 injections in each eye. So what we found very interesting, and it was very reassuring for us as clinicians, was to see that we were able to maintain or improve the vision in 85% of the patients over 3 years. And this is really a very nice outcome when we compare it to real-world data in the world, where we mostly see that patients lose vision very fastly because they are undertreated, and I think this is a nice outcome for our health system. Another very interesting finding was when you look at the red, can you see this? At the red part of the graph, those are the patients that are legally blind. They see less than 660, and this means that they are not able to read or to do any functional thing with their eye. And you can see that over the 4 years of treatment that I'm showing you here, the percentage of blind people was decreasing, and we were mainly maintaining or improving patients' vision. This was achieved by giving them lots of injection each year into their eyes. You can see that in the first year they received more than 6 injection in each eye, and the number was declining over time, and this is something that we know from previous results because usually the activity of the disease decreases with time. Having said that, despite less injections given over the time, we do maintain patients' vision and even improve it. And here you can see patients that see 6/12 or better, and this means that they are allowed to drive with this sick eye only, and this is important for patients because what they want is a functional vision. On the other hand, in Israel we are allowed to take our treatment decisions based on what the physician decides, and even patients that have very low vision can be treated intensively, and even in this group you can see that they received a nice number of injections.